And thank you, Steve, for inviting DPH to participate today. And then Dr. Seals, I think your presentation set us up very well to looking at more specific data related to children. So as Steve said, I am the branch manager of the Child and Family Health Improvement Branch, which is located in the Maternal and Child Health Division of our state public health department. As such, we had multiple programs that look at child injury prevention, and specifically injury prevention as informed by what we understand from child fatality data. We have many partnerships that look at this. And, you know, when you think about a good training, you got to think about what is it we want you to hear, see, or learn from this opportunity. And so one of the things that often comes up is most folks do not have that really clear knowledge of how our local coroners are categorizing those deaths and why they might be categorized in the manner that that happens. The other side of that is looking at those data trends. You've already heard the long-term data trends from Dr. Seals, and I'll get into some more specific child data trends. And then what are we doing in Kentucky? Like, we have a very large state. In some places it's more rural, in some places it's more urban. We have many partners on this. So I have one slide that's going to tell us a lot of details. So the first thing to understand about child death review, dating back many years ago, several decades, is that it needs to be multidisciplinary. The thing that we learned is that having a review at that local level with multiple parties present is probably the most critical point of really understanding the story of why a child actually passed away. The folks who present at these local reviews are the ones who usually responded to the scene, especially in Kentucky, where we have some incredibly small rural environments. That coroner, the EMS, the hospital personnel, the school system usually all know each other. And these cases to them are not numbers and trends, they're a child. And so it's very important to them and to us at the state level to really understand all the nuances of what occurred. And that's what happens from this multidisciplinary team. The actual child death review locally is led and called by the local coroner. Many of our coroners across the state are elected officials. Many will have backgrounds in law enforcement. Others have it in the funeral home industry. And then some are just elected officials with a passion to help their community. They don't have large budgets. You know, I can honestly say the sad side of this is many of your local coroners who are on call 24/7, 365 days a year have an annual budget to do that work for less than $5,000. And so the purpose, as I've said, is just to know what was the story, what were the risk factors that if we had done intervention or prevention could have prevented this child dying or another child dying. What are we learning from this? Making sure that we are uniformly and accurately representing the details to a clear definition. Definition is often the thing that hangs us up. We have many emotions, but we have to be very clinical and objective. We have to be true to that uniform reporting guidelines. Looking at the community level response and communications, and I'll give you some examples of some community level responses later on. And looking
Jan,
at what, yes.
Jan, did you need me to go forward with the presentation?
Oh, yes, I'm sorry. The next slide, please. To child death review, it's slide 3.
Okay.
And then I've got it up on my screen on this side, so I do apologize, Steve. And so then looking at when we do a review, what are the barriers in the community that prevent that community from making a safer environment for those kids? Looking at what can be advocated. You just heard from Dr. Seals' presentation that we need to advocate looking at how we sort that data to include what was asked for by Marcy as to, are we looking at the data from other ways other than male and female? And then ensuring the confidentiality of what actually happened to that family. So while we may talk about stuff in very general terms or de-identified terms, we usually at the local review, it is not de-identified. Everybody there generally knows this family. Next slide, please. And so looking at what's on the death certificate, as Dr. Seals said, we are limited to what gets reported in the data on this death certificate. We learn additional details during a review, but oftentimes our data to have that objectivity and uniformity is strictly what gets reported on the death certificate. That looks at ICD codes, as she identified. It looks at, the residence of the person and many different things. With that, your local coroner is going to identify that a child's death occurs from one of 5 manners. And you'll hear us talk about manner and cause quite often. The manner is usually something that we all get. Natural, it was an accidental death, it was suicide, homicide, or undetermined. And undetermined deaths are those deaths that we don't have enough details to be able to classify them in one of those previous 4 things. A lot of stuff gets placed in that accidental manner of death that with greater details, we can tease it out to a little bit farther, meaning it was an accidental death of a pedestrian in a walkway versus a motor vehicle. And so additional details for cause of death is usually a handwritten piece of that death certificate. A lot of times cause, it may be that it was a natural death, but the cause was pneumonia, or it was an accidental death and it was a motor vehicle collision as cause. So looking at all of these different pieces of information together starts painting the story a little bit more. And so what do we know about our data? And so I will drop in the chat after this our link to this current report where I pulled these data sets. What I can tell you is we're currently compiling the next year and hope to have that released in the next few months. But what do we know? So in 2018, as if you look at the graphic on the upper left, we know that our child death rates kind of rose a little bit in 2016, and we know it started slowly decreasing for 2018. Sadly, if you look at the bottom graphic and do the math of those 2 numbers, you will see that our 2019 death rate will again rise. We expect for 2020 and 2021 that we will see actually higher numbers than 527. That's very alarming and that's very sad, but we know from anecdotal reports and from the information we're seeing from reviews that we had a lot of different circumstances come out of COVID that has created, and I hope you're on slide 5, Steve, that has created different levels of risk for our children who were at home doing homeschooling, from families who chose to do different activities that maybe they weren't as familiar with safety protocols for. And then we have child maltreatment concerns in our state. In Kentucky, we are one of the states with the highest rate of child maltreatment. And as Dr. Seals said, often cases of death related to child maltreatment, neglect, or abuse are not reported on that death certificate. And that's, again, the value of a very in-depth and detailed death review, because that often comes up. That also gives the local team an opportunity for those types of things to refer that for an even deeper dive review with a different state level multidisciplinary team known as our external panel for near fatality and child fatalities, who specifically are looking at the subset of child deaths related to child maltreatment. So we know our death data is probably increasing. We know that a large portion of our deaths in children under the age of 18 is in infants. And if you look at the graphic on the right side of the screen for child and infant deaths, we know 59% of those were related to natural deaths, meaning they occurred because of some clinical causation, whether it be pneumonia, preterm birth, and whatnot. And I'm going to get into this a little bit more as we go along. Next slide, please. And so 52% of child deaths in 2018 were natural. Normally, natural death is the highest reason we have for child deaths. In the past few years, I'll get into some infant information where we see a little nuances in that. Our causes of death for these children for natural actually is in the last 2 years, for 2017 and 2018, stayed about the same. But if you look from 16 to 18, you can see that there were, some pretty big changes in those numbers from 344 down to the 270s. One of the things we know and we recognize in the land of natural deaths is that our prevention efforts have got to be around recognizing those trends for those natural deaths very early on and those causes, meaning are kids getting immunized? Are they getting their routine well child screenings to find things, looking at other reasons for deaths, intervening for those other health conditions or those congenital anomalies early, reducing the risk of cancer. And so the bottom screen, you can see where we've broken the data out. For the number in 2018, we had 24 who died from cancer. We had 76 natural deaths in infants related to congenital anomalies or birth defects. When you think prevention of birth defects, one of our biggest successes has been in the promotion of folic acid or taking a multivitamin daily for women who wish to be pregnant or are pregnant. That reduces the risk of spina bifida. Looking at other health conditions or perinatal conditions that led to death. And then preterm births. In the state of Kentucky, we still have an incredibly high preterm birth rate. And then those kids are at one of the highest risk of having a natural death. And then if you look at, we broke out congenital anomalies on the right, and you can see that between that period of time, we've stayed somewhat stagnant, even though on the graphic, it looks like it's a nice big W, but we've still run with about 100 deaths per year related to those birth defects. Next slide, please. And so then our next big category that you will find is the unintentional injury death or accidental death. In the state of Kentucky, if you remember, I said we have about 500 to 600 children's deaths a year. If you look at this particular graphic, you can see that about 20% or greater of those is generally related to some form of accidental death. Next slide, please. The next set of slides will tell you that 16% of those accidental deaths was in babies before their first birthday. That's a lot of infant deaths. When you think about that, about close to 20% of the 500 total is babies who will never see their first birthday. That's like saying an entire school of kindergartners don't reach their first birthday. That's a lot of babies that don't make it. 41% of those are related to motor vehicle crashes. It's still one of our highest numbers for why children die. It's one of the things that if you talk to anybody in Safe Kids out in the communities who are doing child seat checks, they're the folks who are going to tell you the importance on appropriate child passenger safety restraints. It's very important that they're placed in the safest place of the car, in the back seat, in the middle. It's very important that they have car seats or booster seats that fit the right way or are turned the right direction. All of that is what we look at as we look at these death records. We also know that we have a good number of suffocation, strangulation, or asphyxiation as far as accidental death. A lot of those will end up being related to safe sleep, and the suffocation or asphyxiation will occur not just from parent rollovers, but from things when they were in an actual safe sleep environment or crib with an appropriate mattress, that they may have other things in that crib with them. We see things during review and in pictures from the normal stuff that you think about with children, from stuffed animals and blankets and things that shouldn't be in there. We also see the laundry. We see equipment the family has dropped over into that crib while they're working on the window or whatever. So again, reminding parents that safe sleep also includes looking out for danger, looking for those other things in that crib. And then we have the drowning deaths. We have a lot of very wonderful places to vacation in Kentucky. We have lots of natural lake waters. If you look down in Laurel County or out west of Barren River, there's plenty of places for people to go boating. There's places where people do cliff diving. Not that we encourage that by any means, but then there's a lot of folks who just don't get swim lessons. And they also die in our local swimming pools or in private pools that have not had necessary safety equipment around them. Next slide. And so our next slide on homicide is the other thing that you heard Jacqueline mention earlier when she was speaking. We know our homicide deaths are rising. We know that 76% of homicide deaths in 2018 were in children. That is rather alarming to think about how many kids died because of some other person harming them. We know that 59% of those were related to firearms. So talking about prevention, you know, as Steve led off with saying that we, sorry, I just saw something pop up on my phone. I do apologize. I lost my stream of thought. We know that with firearms, we need to think about storage. We're not advocating for folks not to have a gun. We're advocating for that gun not to be made accessible where children could get to it and accidentally discharge it and harm themselves or another. We know that with firearms, we need some safety mechanisms in place to prevent those folks who may have, you know, intent to harm, that's not accessible for them. And we have some laws around that, but there's always more we can do. We also know, if you look at the lower right side of this, that we had homicide deaths related to abuse, you know, lacerations, beatings, that type of thing. We know we have a lot of homicides where some of that causation or mechanism is just not clearly known. It's unspecified. You know, I really want to know more about that 29%, because when I think, how do we prevent a child dying from this type of harm, you know, what is it we need to be thinking about? And when, you know, the question came up about ACEs and adverse childhood experiences, as noted, that's not on our death certificate. However, it is a very critical thing we will hear those stories about in that child death review. And so it is very important that we do think about what are the mechanisms for child homicide? What is the reporting around that? The more we can clearly report child abuse and neglect, or report to our external panel if there was suspicion of a child death or near death related to child abuse and neglect, the more likely we're going to identify some of those systems changes that we need to talk about. Next slide. And so suicide, that's the next one. That would be one of our top 5 manners of death. And so with suicide, if you look at the data, you will see that our numbers are rising. In 2018, we had 25. We fully expect that in the next annual report, we will see numbers that are 30 or greater. We know that the rate of near fatality from suicide or suicide ideation or attempts has also risen. The thing we know about child suicide is that in that data, the ages are getting younger. Children as young as age 8 have reported having ideation for suicide, and we have had death reviews done on children as young as age 10. There's a lot going on when you have a suicide review. You know, when we look at the percentages, the amount of children who have suicide are more likely to occur in men or male children versus female. And we know that the delineation of child suicide differs between hanging and firearm, with firearms being more likely. Again, there is that opportunity to reach a firearm that is either not stored or is accessible to a child or teen. The problem with suicide is really understanding that those numbers that are being reported are probably lower than the actual numbers of true suicide deaths. On the death certificate, our medical examiners have to have reliable information and proof that this was truly an intentional death and therefore suicide. Oftentimes when they go out to the scene, there's no note. They'll hear stories that the child was happy, there was nothing going on, there was nothing going on at school, and they cannot rule that as a suicide. Many cases will end up being undetermined or considered accidental if there isn't some real documentation around the fact that it was suicide or that there was something going on to identify it as that. So when I say there's a number in 2018 of 25, in reality, some of the other cases we looked at was very likely suicide related. Next slide, please. And then undetermined. It is also interesting to note that 68% of our child deaths occurring out of state were considered undetermined. Oftentimes, we have a really difficult time across state lines getting information about a child's death. We can ask repetitively. We will reach out to other state child review committees, and every state's child review committee design and structure is a little bit different. Every different state and what the information they collect is different. And then the coroners in those areas, the information they collect could be different than how we manage it in Kentucky. And so we get limited information. And so what is alarming is that there could be a lot of things that happen literally right across state lines. Imagine how many children die just across Jefferson County line or just across the line in Tennessee or West Virginia. You know, this could be things where they're hiking, they're swimming, they're in motor vehicles, but we can't understand how to prevent in that arena without data. We can't guide our Kentucky families without that data. We guide from the level of what we know. And so we do reach out, we do attend a lot of federal meetings, we have discussions with them. We have some shared cases where we have invited out-of-state parties to attend to try to resolve having this fall into an undetermined category on a death certificate, but at least on the side of the review that we have some knowledge so we can think about, you know, if you're traveling, do this. It represents cases in undetermined that there's just not enough details known. You know, you can imagine if a coroner goes to a scene where a family has reported that an infant has passed away and they have stripped the crib and the bed and they've cleaned the house and their stories are not matching and an autopsy is done and it doesn't find anything, that this thing is ending up undetermined because they really don't have any information to figure it out. Those again are those things where we have to do a lot of prevention and promotion around a complete death scene investigation. Next slide, please. And so that brings me to prevention efforts. And so prevention from a public health promotion is to look at the problem, look at your data and your surveillance. We've talked a lot about that between Dr. Seals and myself. Looking at evidence-based practices, if there aren't things already in a community, what can be developed? Then promoting and implementing your action steps, and then going back to evaluate them. A simple example of this was in one of the counties where they noticed they had a larger number of children being hit as they were walking to a particular bus site to catch the bus. There was no lighting along this country road, as we know in rural Kentucky. There's no port sidewalks. You know, this was an area in which kids had been hit by other vehicles, many with some pretty serious injuries. Then a death occurs. So then this particular community went out and they walked the path that these children were walking. They worked with their local school and they got some local volunteers to come out and create a safe walking path. They also sent out postcards to every single mailbox within their county, advising them of the times the buses would be running and letting them know these are times to be more cautious when walking, when driving around these local roadways so that they could be more aware that children could be on the sidelines trying to get to a safe bus stop. You know, the other thing they did was where they could, they asked the local rural electric company to install some lighting, you know, some different community lighting on those roadways that specifically went on, you know, for when children would be walking to or from school. That was a pretty large community response to fix a problem that they identified out of review. Prevention has to move from the land of evaluation and data to getting into figuring out what was the sentinel event, what was the reason this occurred, and getting into some primary prevention, which was that actual thing, but then looking upstream. You know, we could say, well, we're going to take all kids to that particular bus stop and drive them, you know, each parent will drive them in their car, but that's not realistic. So how did we get an upstream way? They started doing education, doing promotion, building a place where they could walk safely, getting community partners to create more lighting. So that's where we got to always think about with prevention. I can do that thing today for this one person, but I've got to expand it. So next slide. And that gets us into a whole lot of different opportunities. Media campaigns have been a really big resource during COVID, with so many of our local health departments unable to get out in the community to host, health fairs, safety fairs, go to their local, fairs, put up vendors, things at conferences. There's lots of ways we've always used where we were there in person. We can no longer do that. So getting things out there on social media, whether it be Instagram, getting things out that are timely in advance of when we think people are paying attention. The first warm snap that we have every spring, we will have reports of an ATV accident, so talking about, not letting your 9-year-old drive alone in the woods on an ATV, talking about if you're on a bicycle, it's a warm day, reminding those children that they need to have their bicycle helmet on. What are the bicycle safeties? They may have followed the rules the previous summer, but it's a good time to promote and remind. Radio spots became a big thing in the last year, with lots of our local health departments taking advantage of PSAs out on the radio. They talked from a multitude of topics. I've listed 2 here, but also just thinking about where you're at, reminding the providers, talking to your doctors, talking to your schools. How do you all have things? Can you put stuff up that's on your page that has safety information or has the suicide hotline? We had a lot of places just at the local sports arenas, whether it's the football field, the basketball court, or wherever, put up posters with the suicide hotline so that these adolescents are constantly seeing that, so they know who they can reach out to and call. Safety kinds of giveaways with these things like Steve mentioned earlier, with gun locks, medication storage containers, smoke alarms. We still have a lot of residences that do not have a smoke alarm, which can lead to fire death. We have Cribs for Kids programs through our local health departments. Not all, but many participate, in which if there's not a safe sleep environment, you can reach out and ask the question or ask somebody to call them. And many of them will have an actual pack and play crib that can go for travel as well as at home, that they can give to the family. So to prevent deaths related to some unexpected infant death because of a lack of a safe sleep. I really want to call out Fayette County. They did a phenomenal job of getting education into the hotel rooms at all of their hotels. So if you remember, when you shut the door, it tells you your emergency exits. It tells you information about checkout, that kinds of things. Well, they have safe sleep materials now posted. That's huge, because every year we will get reports of infants that died because they weren't sleeping in an appropriate surface at these areas. They also talk to the management or owners of these areas so that question's being asked at check-in. Do you need a crib for your baby? We have those. They got a lot of community involvement just around working with their local health department, hotels. Every guest getting asked is a huge change, because a lot of times, as we all know, we pull into the hotel, we're exhausted. Somebody walks in and does the check-in while somebody else is unloading that luggage. What a lovely time to take care of this right up at the front. It also provides a great customer service piece and positivity for that local establishment. In Mason and Buffalo Trace, we thought about child maltreatment. That was something they had a lot of concerns about. They identified that locally. They went into their local prisons and places. They talked to their law enforcement, and they started teaching the Kentucky Strengthening Families curricula. That's kind of huge, because what it taught these folks who are incarcerated, who might have children when they get out, is that how to cope, how to respond with different language versus striking out and hitting. One of the best stories that came out of this initially, when this very first began, was one of the local wardens actually called back to tell the health department that he had less fights between inmates after they started doing this curricula. It became such a positive thing that our Justice Department has recognized it as a reason to shorten sentencing for those folks who complete the entire curricula. Drive-through events. We have had things from baby showers, who did kind of multiple stations where they got some sort of freebie or swag. that had educational material on it. But at each stop, they got to learn a smaller piece of that information, breaking it down into something easily absorbed. So if you went to the first station, and let's say you were talking about safe sleep, you might hear just what A was, that the baby needs to sleep alone, not with others, not co-sleeping. But then at each station thereafter, you got it. And then by the last station, your big prize came when you completed the survey. So we could actually understand how much did they learn as they drove through this environment. This has been utilized by hands. It's been utilized with trunk or treat. It has been utilized in many ways to get that safety information out there. As I mentioned, health fairs are always a great place to capture people. If you've got that 10-second messaging, if you talk to Xenia Robinson, I think she had about, I don't know, a few thousand children who did one of two things. While she talked to them how to be safe, how to participate in sports safely, how to ride in a car, how do you get out of a house if it's on fire, what do you do if you're swimming? She got all kinds of information out at that state fair. And for every single child who answered a question, she gave them safety information or health information. It was a really good opportunity to multi-message. Not only was she able to engage just the child, she had the parents hearing the same messaging as she was doing it. It was incredible. I also have to say, I enjoyed as she got many kids to do jumping jacks and exercise while she talked to them. Safe Kids, which is where Xenia and Sherry Hannon are from, has a couple chapters here in the state of Kentucky. They are just vital. Our Fayette County chapter is incredible with working on getting child passenger safety trainings in more than just Fayette County, working with our local fire and law enforcement on how to do those child safety checks, looking to see and train the parent on how to install their own seat. Again, extending beyond primary prevention. They also do a lot of outreach and education, finding stuff from Safe Kids Worldwide that we can post statewide on social media. So they're a huge partner to DPH. Safe Sleep, WIC, Hands have also delivered safety bags to hospitals so that every time that new bag goes out with that new mama, there's something in there for safe sleep. Our hospitals are doing the education with every single child born on pediatric abusive head trauma. They're doing education related around safe sleep. At the same time, they're trying to help a new mother who just gave birth 24 hours ago understand how it is to be a new mom. That's where those referrals to Hands come in for further safety, because Hands has a curricula that looks at safety in the home. And then looking at our zero suicide work, we partner with our Department for Behavioral Health, and we're in a federal collaborative right now looking around what's driving the suicide rates in the state of Kentucky. We're not unique for that in Kentucky. What I can tell you is that if I look at Region 4, which is where Kentucky sits, in maternal and child health, we hear the same thing out of our sister states. And so everybody's trying to figure out the zero suicide framework is really a wonderful framework that is a systems-wide change. It's looking at what are the policies and procedures in a healthcare provider setting, in a school setting. How do you evaluate your policies? Who's the first line person that can respond if a child says that they are thinking about it? How do they respond? What we find is often most folks need more training. They feel like they're okay to know I got to refer, but they really don't know how to physically respond in that moment to keep that child safe. So figuring out how we can connect to those resources. And then looking at trainings. You'll hear at every single child fatality review meeting that somebody's doing some kind of training related to protecting children. Steve Sparrow and Ashley give out multiple links to stuff that's sitting over at K-SPAN. We give out stuff that sits on Kentucky Train. Safe Kids has things that they do. And we're all trying to get that messaging out there, getting it to the level of our nursing schools, our social work, our EMS. We hear every time we do a needs assessment, everybody needs more information, more education to feel comfortable about that. Looking at things like poisoning prevention, ingestions, that's another big topic. We know with our opioid epidemic, we have a lot of children who have access to the medication of the parents who may be taking something in response to their opioid addiction. So how do we help those parents keep their medication stored safely, and figuring out what all those things are. I used to work a lot with child cares, and one of the big messaging in pediatrics when you have young children is get down on your knees to the same eye level as that child and reminding them this is important. So when we talk to pediatricians, to remind parents to do that same thing, because the plugs, and the items that are at that child's level oftentimes go unrecognized. We think we have stuff out of reach that we don't. So I think that's the end of my presentation. Are there any other slides, Steve?
I don't believe, no, there's no other slides.
All right, so I've covered a lot very quickly. Does anybody have any questions?
Dan, Joel had a question in regards to seat belts. Did he hear that car seats should be in the middle? Is this true for rear facing infant seats? And it just moved, sorry. Is this true for rear facing infant seats and front facing seats?
So we talk about, Joel, the safest place for a child to be in a car is in the middle of the back seat. Depending upon your car seat and the age of the child, there's different variables. So the big thing on that, I would defer to Xenia Robinson or Sherry Hannon, because they can give you the correct facts more so than my generality.
Thank you, Jan. I'll follow up with them as well, because I had a question in regards to single cab trucks where a child should sit safely.
Correct. Yeah, there's lots of nuances to child passenger safety and placement of car seats, size of car seats, and rear facing, forward facing, and I'm by far not that expert, so I will defer that to our experts on this panel.
All right. Beck Whipple also put the Zero Suicide initiative that you were discussing in the chat box for everyone to view. There is a link to the Safe Kids Fayette County presentation on child poisonings on home prevention that has been placed there at 6:30 p.m. on November 15th. So we invite you to join us. It is free. Be some great material. And then I had a question, Jan. As you're looking at the CFR and DPH, have you been noticing anything noteworthy in regards to unintentional overdoses among children?
Yeah, I don't have any specific data to that, Ashley, but it is something that comes up during review, especially in some of our accidental deaths related to poisoning. And it does seem that we're having a rise in accidental ingestions.
Okay, are these, do you know anything about the specifics of the content of what contents they're ingesting or anything?
A lot of it is the medications that the parents have been prescribed or gotten from the street related to their substance use disorders. And so it's something that our external panel is looking into about that. I think Dr. Elizabeth Salt at UK has been trying to gather some more detail around that as another resource, but I don't have any specific data for that.
Okay. And then I have one more question in regards to fentanyl-laced marijuana. Or does anyone have any information in regards to the use of that among our adolescents?
So what I can tell you is from our death reviews, we have had some deaths related to fentanyl-laced medications, or not just marijuana. I have heard more about that on the national scene as being more common in the college age population who are taking stuff when they're very stressed, or they're trying to get Adderall off of their roommate or whomever to try to study. And then we're having those subsequent deaths because of that. We don't have anything specific related to that particular data set coming out of the reviews, but it does come up, and there, during the autopsy, you'll see what the substances are if toxicology is done. Toxicology is another big issue that we find in child death review, that many of the decedents have not had a toxicology study done, or the caregivers of the children have not had a toxicology. So there's kind of two sides where we need to really get more information on. Toxicology, getting that completed at the point of autopsy is an expense in an already cash-strapped situation in the land of child death reviews.
Okay.
So do you
Thank you.
feel that, the big, for monetary, the financial is the biggest barriers for getting those toxicology postmortem reports?
I think it's a much larger discussion. It's one that there's been a task force created out of our external panel. So I don't want to try to take a guess at it, to be very fair.
All right, well, thank
Right.
you.
Thank you, Jan.